Hello guys, welcome to the Parson series, and this is your chapter number 2, part 2. We'll try to complete this chapter today. Alright, so in the last session we had already discussed about the different aspects of the aqueous humor. Now we'll be doing the circulatory part of the aqueous humor. Circulation of aqueous is necessary both for metabolic purposes as well as to regulate the intraocular pressure. Now, because aqueous humor is the main constituent which is responsible for giving nutrition, and those nutritive materials are actually required. Some of them are required for the metabolism. So it is actually important for your metabolic purpose, and secondly, of course, that it is helpful for maintaining the intraocular pressure. Now, as the greater part of the fluid is formed in the ciliary region, it flows from the posterior chamber through the pupil into the anterior chamber and escapes through the drainage channels at the angle by the trabecular meshwork, Schlem's canal, collector channels, aqueous veins, and going into the episcleral veins. So, this is simply they are telling you about the drainage pattern. So as we draw this diagram in the classes also, this is your the 6 layers of the cornea, and then we have got the iris here. See this is your iris, and the ciliary body is something like this, and then you have the lens. Okay, now these are your ciliary processes. These are your ciliary processes. So they are actually telling you the direction for the drainage of aqueous humor. So what will happen when aqueous humor is released here? So where it is coming in the beginning, it is actually coming in this posterior chamber. This is your posterior chamber. Are you able to visualize it? Yes. So this is your posterior chamber, and what is happening? This is your pupil, right? And this is your anterior chamber. So the direction of flow will be, it will be coming through the pupil, then it is coming in the anterior chamber, and from the anterior chamber, then it is going in this angle here, it is going in the angle here, and majority is passing through this trabecular meshwork. So the trabecular meshwork is actually present, at this angle here. It is a sieve-like meshwork or spongy meshwork, which is cribriform, having so many pores. So from here it is going to pass here. So we have got different structures. This is your trabecular meshwork. Then we have got a canal here. This is your Schlem canal. Schlem canal is also there, right? And then it is passing through the aqueous veins, going into the episcleral veins. So these are called as the collector channels. So this is your aqueous veins here, and this is your episcleral veins, right? And that is why, when episcleral veins have a high pressure, we have got increased episcleral venous pressure, actually it leads to the reverse changes. We have got the features of raised intraocular pressure when we have the raised episcleral venous pressure. So same thing they are saying here. We have got what you called as the trabecular meshwork, Schlem's canal, the collector channels, aqueous veins, and into the episcleral veins, right? Now, in addition to this, we have got a smaller one of this trabecular pathway was responsible for about 90% of the aqueous drainage. So, second, we have got a smaller one also. So this smaller is the uveoscleral outflow. Now, this uveoscleral outflow allows aqueous to flow through the ciliary body into the choroid and the suprachoroid, and from there into the episcleral tissue. So that in cases of uveoscleral tissue, now though we will be dealing it in detail in the topic of glaucoma, but it is actually uveo, it is uveo and then it is scleral, right? It is uveo and then it is scleral. So it is coming from the ciliary body, then it is going into the suprachoroidal circulation, and from the suprachoroidal circulation it is going into the scleral tissue. So it is a smaller route and it is mainly through the veins. Now, if you look at the intraocular pressure, now this is going to be an important one. There are so many things which are important about the intraocular pressure, and nowadays they tend to ask you questions related to it. Now, the major factor which is controlling the intraocular pressure is the dynamic balance. It is actually the dynamic balance which is between the aqueous humor production in the ciliary body and its elimination via the canal of Schlemm. So they are saying that intraocular pressure is nothing but a balance between the two. On one hand, you have the formation of aqueous humor. On the other hand, you have got the drainage through the canal of Schlemm. So the maintenance between the two is your intraocular pressure. Other factors like choroidal and vitreous blood volume, the extraocular muscle tone, they can also affect in the shorter term. So now whenever we have got a pressure, obviously there are so many things which are controlling it. Even the position, we have diurnal variation, have you drink water or not, there are so many things. But the two important things is your dynamic balance between its production and its elimination. So production and drainage remains the most important thing. Prolonged changes in the intraocular pressure are controlled by two factors. Now what are these two factors? Let's see these two factors. The alteration in the forces determining the formation of the aqueous and the alterations in the resistance. So obviously again they are saying that the things which are responsible for the formation of the aqueous humor and the things which are responsible for the resistance, they are offering the resistance to its outflow, obviously will affect the net amount of aqueous humor. So if I have alteration in those things which are forming the aqueous humor, either there is very less formation or either there is very much increase in the formation, or the things which are offering the resistance. So at times we have got increased resistance. Now whenever you have increased resistance, maybe due to the changes in the trabecular meshwork, we have the inflammatory cells, we have pigmentary cells, we have sclerosis and any other thing, then I will have less of drainage, and less of drainage will again lead to more and more amount of aqueous humor. More amount of aqueous humor will again lead to raised intraocular pressure. From the clinical point of view, the latter is more important. Now sometimes you have this dilemma that if both are given in the options, then what to do. Then they have clearly said that latter is more important. So most of the time when you get glaucoma, you do not get alteration in the formation. It is only in the hypersecretory kind of glaucomas where you have more amount of formation. So mostly we have facing of this problem that there is a resistance to the outflow, and that is why we have raised intraocular pressure. A rise in intraocular pressure may be caused either by a process which blocks the passage of aqueous humor into the canal of Schlemm, like I can have the sclerosis of the trabeculae, or the obstruction by the exudates or organized tissues, or we can have increase in pressure of the episcleral veins which are draining into which we have the drainage of aqueous veins. In either event, glaucoma is the result. So what they are trying to say, that mostly we have a problem in the drainage, and 90% of drainage is by trabecular meshwork. So we have the blockage in the trabecular meshwork. Now this blockage in the trabecular meshwork can be occurring by so many things. I can have sclerosis, I can have obstruction by the exudates, I can have organized tissues. So if you remember, I told you that whenever we have got the trabecular blockade, whenever we have the trabecular blockade, we always have the open angle glaucoma, because when anything is blocking the trabecular meshwork, like it can be exudates, that is inflammatory cells, pigmentary cells, or if we have some organized tissue, or I have sclerosis, anything. So that is leading to the obstruction of 90% of aqueous humor. So 90% of the aqueous humor is not able to pass through. So obviously there will be decrease in the outflow. So obviously there will be decrease in the outflow, and when there is a decrease in the outflow, net aqueous humor will increase, and obviously we will have glaucoma. Alright. Now if the drainage channels to the canal are blocked, Okay, then they are saying that if the drainage channels to the canal of Schlemm are blocked, some drainage will take place through the uveoscleral. Now obviously we are saying that we have got a smaller outflow also, that is uveoscleral, so only 10% or 10 to 20% will continue to flow, so majority will face the resistance. Inefficiency of the drainage channels therefore cause either a cumulative rise of the pressure or the transient increments. So if I have some insufficiency in these drainage channels and the aqueous humor is not able to pass through, I will have the increments in the intraocular pressure that can be continuous also and that can be transient also. Well, these are the principal factors determining the prolonged changes in the intraocular pressure. We have other factors that cause the temporary effects. Now, these are the things that could be asked in the form of MCQs. Let's see one by one. The first important thing is variations in the hydrostatic pressure in the capillaries. Now this is, a physical factor. Obviously whatever is the hydrostatic pressure lying, now this is a simple pathology. Okay, so you have read this, that if you have increase in the hydrostatic pressure in the capillaries, the net pressure inside those will increase. So obviously I will have increase in the intraocular pressure. Then second, if there is an increase in the permeability of the capillaries, if I have increase in the capillary permeability, okay, allowing the formation of plasmoid aqueous with high protein content. Now normally I do not have that vascular permeability, so I do not have the large proteins, okay, and that is what happens in cases of uveitis. Due to the damage to the endothelium, we have increased vascular permeability, we have release of proteins, and we have aqueous turbidity. So what is happening in cases of especially the inflammatory cases, when I have increase in the permeability, I will have the presence of high protein content. Now this high protein content will do what? It will increase the osmotic pressure relative to the blood. So now the osmotic pressure of the eye will be lying on the higher side in comparison to the blood, and thus there will be rise in the pressure of the eye. Okay, so this you have to remember, as I told you, in cases of the hypertension uveitis, especially in the cases of the hypertension uveitis or the inflammatory glaucoma. Then we come to the change in the osmotic pressure of the blood. Now if there is other way also, now either there can be a change in the hydrostatic pressure of the capillaries, or I can have the change in the osmotic pressure of the blood. So what is happening, if I have a change in the osmotic pressure of the blood, this can be also reflected by the intraocular pressure by altering the process of diffusion across the capillary walls. So now the pressure gradient, the direction in which this fluid will be flowing will obviously be reversed, and there will be hypotonicity inducing a rise in the intraocular pressure as in the water drinking test, and we can have hypertonicity, that is there will be a fall as induced by the glycerol by mouth or mannitol. Now this is a very important thing, very important thing. This point is very important. It is explaining you the working of hyperosmotics. Hyperosmotics which are working very quickly, and we have a quick decrease in the intraocular pressure when you are giving the oral glycerol or you are giving the IV mannitol, how it is taking place. So this is taking place by changing the osmotic pressure of the blood. So what we are doing, by when you are giving this hyperosmotics, there is actually hypertonicity. Okay, hypertonicity will lead to a fall. Okay, why? Because there in the blood we have hypertonicity, so now the fluid will start flowing from the eye to the outside, and therefore there will be decrease in the intraocular pressure. While what is happening, hypotonicity, if there is other way around, hypotonicity is caused in the water drinking test. When I am giving the water, then there will be increase in the intraocular pressure. So they can also ask you that what is the reason behind the provocative test that we are doing, water drinking test. So the reason behind that provocative test is hypotonicity. So this word is again important. All right. Now coming to the other one, that is your volumetric changes. Volumetric changes within the globe are immediately transformed into the pressure changes owing to the indistensibility of the sclera. Now you know that in adults the sclera becomes rigid, it is not distensible. Like we have buphtalmos in cases of the children or the infants who are less than 3 years. But if you see the adults, what is happening, if there is a changes in the volume, then they are immediately transformed into the pressure only, because now this volumetric changes cannot be equally distributed and that cannot lead to distension of the globe. Okay, so what is happening, like if I have the extensive vitreous hemorrhage, they have given you a very easy to understand example. Suppose I have got very high vitreous hemorrhage, then will I have the raised intraocular pressure or not? Yes, the answer is yes. The reason is that the sclera is not rigid. If the sclera is very rigid, it is not elastic in cases of adults. If it occurs in the children, then up to some limit it is able to manage it, compensate it, because what happens, it will be leading to the distension of this sclera. But in adults this is not possible because the sclera is rigid. That is why it will immediately lead to raised intraocular pressure. Then the next one, blockade of the circulation of the aqueous, blockade in the circulation of the aqueous. Now the blockade in the circulation of aqueous has a profound effect also in the ocular tension. So that can take place at two places. One will be taking place at the pupil, where the flow of fluid from the posterior to anterior chamber. So if there is a blockade at the anywhere in the root of the flow of aqueous humor. Now we know that it is flowing from the posterior chamber through the pupil and then coming to the anterior chamber. So if I have any problem at the level, of pupil, obviously that will lead to raised intraocular pressure, because that will interrupt with the drainage. So pupillary block. Now if I talk about the pupillary block, this can be like pupillary exudates, or it can be seclusio pupillae, it can be occlusio pupillae, means if the pupil is blocked due to any reason. The second important thing is that the drainage is obstructed at the level of the angle of anterior chamber. At the level of angle of anterior chamber, it can be obstructed, so obviously that will be your angle closure glaucoma. If you want to correlate, okay, then you can correlate with your notes also. We read this, that there can be obstruction at the level of pupil that was leading to the flat anterior chamber. This we read in the post-operative complications of cataract surgery, flat anterior chamber. Then it can also lead to the obstruction at the angle of anterior chamber. This we read in the angle closure glaucoma. Then if you talk about this obstruction in the situation at 1, so they are saying that why you can have pupillary block. They are saying that there are two reasons. The first arises in the eye with a shallow anterior chamber. A lax iris has a larger area of opposition to the anterior surface of the lens, causing the condition of relative pupillary block. Now what they are saying, how we can have pupillary block, they are trying to explain it. They are saying if you have already very shallow anterior chamber, so obviously the chances of the opposition between the what you called as the iris and the cornea are very high, because the anterior chamber is very shallow, and that can lead to relative pupillary block, not the total pupillary block. Okay, this is one thing. So what will happen, the iris billows forward to reach the cornea and blocks the angle of anterior chamber. So actually here they are talking about the iris Bombay formation. Here they are talking about the iris Bombay formation. Now let me explain you what is this. Suppose this was your cornea, and we were having the iris also like this, and the ciliary body and lens was there, not a problem. Now they are saying that suppose this is shallow, it's very shallow here. So what is happening, if it is very shallow, then the slightest of changes, suppose there is some dilatation of the pupil or the iris is lax, then what is happening, it is going anteriorly and it is forming the iris Bombay formation, that is ballooning of the iris towards the cornea. So this will again lead to the relative block. This will again lead to the relative block of the pupil, and this actually iris Bombay, that is ballooning of the iris towards the cornea, this iris Bombay can lead to the acute congestive glaucoma, sudden closure, and this can lead to your Synechiae formation, and then Synechiae can lead to chronic congestive glaucoma. So pupillary block in this way, now this is the main mechanism how the angle closure glaucoma used to happen. So I think you are able to correlate the two things. Okay, so see, they are saying that if there is adhesions, we can also have organic adhesions between the iris and cornea, where the iris becomes adherent to the anterior capsule of the lens in the primary angle closure glaucoma, inflammatory conditions, neovascularization, and you can have the development of the secondary glaucoma. So you can have the adhesions. So they are talking about both the anterior synecdoche as well as posterior synecdoche. I know you must have blocked here that they are saying that the iris becomes adherent to the anterior capsule of the lens. So here in this condition, actually they are talking about the posterior synecdoche. So if you remember, in the posterior synecdoche, I told you about the ring synecdoche. The ring synecdoche was the most important synecdoche that was leading to the glaucoma. So in the ring synecdoche, there was adhesion between the iris and the lens, and that was leading to the aqueous collection. And this aqueous collection was leading to again the iris Bombay formation. This was again leading to the iris Bombay formation, and the whole chain will be repeated. Now again you have ballooning of the iris towards the cornea, you have the closure of the angle of anterior chamber, you have then you have anterior synecdoche, and then you have the synechial angle closure glaucoma. Alright. Now let's move forward. The intraocular pressure within the eye. So they have given you the normal range. It is 10 to 20. Now you will say, ma'am, you say that it is 11 to 21. So this is also correct. Like all books say somewhat here and there. So roughly it can be 10 to 20 or 11 to 21. Even so they say 15 to 21. So somewhere in the range it is okay, normal. It is most accurately measured by the manometry, wherein small cannula is inserted in the anterior chamber connected with a small mercury or the saline manometer. Now see, it is manometry. Manometry means it is manual. So manually they are calculating the pressure, that is intraocular pressure. They are inserting the cannula in the anterior chamber and straight away. So obviously that will give you the most perfect and the most accurate intraocular pressure. Such a technique is used experimentally on animals, but obviously in humans you cannot do this. So for this we are using so many tonometers. Okay, the sclera is only very slightly elastic and rendered tense by the internal pressure, allowing the intraocular pressure to be measured by the degree to which it can be indented. Now because you know, practically it's not possible to insert a cannula in the anterior chamber in the living human beings and measuring the pressure. So what we are using, we are saying that practically speaking, the sclera is very rigid, and whatever pressure is increased, it will be exerting the pressure on the walls of this sclera. So we are using this information to calculate our intraocular pressure. Okay, so they are saying that the intraocular pressure to be measured by the degree, you have to calculate by the degree to which it can be indented on the application of the weight, or it can be flattened. So indented, this we are using for the indentation tonometer, while the flattening, this we are using for the applanation tonometer. So we are using these different informations and different principles in the two separate tonometers. Okay. Such a method is used in tonometry that you will be seeing in the clinical examination. The result is obtained, usually recorded as millimeter of mercury, that is the unit. Okay, by standardization with the manometer on experimental animals, and that is intraocular pressure. So you have seen the drainage, how it can increase, what are the conditions where it is increased, how you can measure the intraocular pressure. All right. Now let's see the metabolism of the ocular tissues. First, we'll talk about the vascularized tissue of the eyes. The vascularized tissue of the eye means we are talking about the uveal tract. So in the vascular tissues, it is same. It is similar to the other tissues in the body. It's not very different. But if I talk about the number 2, that is your non-vascularized tissues. These tissues are mainly your cornea and the lens. So they depend for their energy requirements essentially on carbohydrates, which are utilized by phosphorylation and auto-oxidative mechanism. So crux is that If I talk about those tissues which are vascular tissues of the body, not a problem, you know already. But if I talk about those areas which are avascular, not vascularized, then they are simply dependent upon the simplest form of energy, that is carbohydrates. So for that I will be requiring the phosphorylation as well as the auto-oxidative mechanism. Now coming to the cornea first, the cornea has low energy requirements. Okay, so this energy is required for the replacement of its tissues as well as the maintenance for the transparency. It does not do many things as far as the metabolic requirement is concerned. So you have to change the epithelium and you have to maintain the transparency. For that we require the energy. The transparency essentially depends on the state of relative dehydration, and relative dehydration is maintained by the metabolic pump, which is maintained by the active transference of the fluids through the epithelium and the endothelium. Now a fall in the metabolic activity, okay, or increase in the permeability of the membrane leads to edema and opacification. So I think this is very clear. We have discussed in detail about the cause of the opacification. Whenever you have aging, that aging leads to overhydration because of the decreased efficiency of the sodium potassium pump, and that decreased efficiency of sodium potassium pump occurs mainly due to the aging. Okay, so when you have got suppose aging, that is leading to the decreased efficiency of your sodium potassium pump. This will lead to the overhydration of the lens, and this overhydration of the lens actually leads to the cataract. That is your opacification. So they are talking about the same thing here. No, not the cataract here. They are talking about the cornea here. So that is your corneal opacification. The method is same there in the lens also. So they are talking about the corneal opacification here. Okay. So this is how the corneal opacification is taking place. Now the essential physiological differences between the cornea and sclera are that in the cornea the fibrils are arranged in a regular lattice work in a ground substance of mucopolysaccharide, whereas in the sclera we have irregular arrangement, and that the formed tissue is formed by the cellular membranes which control the traffic. Now this is again very important. We will be talking in detail while we are discussing the topic of cornea there, that the main reason why the cornea is actually transparent is that the fibrils are arranged in the regular lattice work. That is also called as the Morris theory. Now what happens there? In the cornea, the fibrils are arranged regularly, okay, parallel to each other, and the distance between the two fibrils is less than the wavelength of the light. So when the distance between the two fibrils is less than the distance, the wavelength of the light, you know, whatever are irregular rays, they are actually destroyed by the destructive interference. So that is also a very important reason why I have the transparency in cornea. Then I have relative dehydration due to sodium potassium pump, avascularity is also there, I have normal intraocular pressure. So all these things are collectively responsible for making the cornea transparent. Cornea derives its nourishment. Now because it is avascular, it is important to know that where from it is getting its nourishment. It is getting from three sources: the oxygen directly coming from the air also, then you have the solutes coming from the perilymbal capillaries as well as aqueous humor. So while the lens is actually mainly dependent upon its nutrition over the aqueous humor, the cornea is dependent upon three things. We have got directly air also, then we have perilymbal capillaries as well as the aqueous humor. Now if I talk about the oxygen coming from the air, so that is an active process undertaken by the epithelium, and in the atmosphere of the nitrogen, lactic acid collects rapidly in this layer of the cells. The importance of diffusion, if I talk about the second thing, diffusion from the perilymbal capillaries, it is seen clinically in the relative resistance of the peripheral parts of the cornea to the degenerative changes. So when I come to the diffusion from these perilymbal capillaries, okay, I can face certain areas of the resistance, and that can lead to the degenerative changes in the cornea also. But if these vessels are experimentally cut, corneal transparency is maintained. It has been seen that when we are cutting these vessels, even then the corneal transparency is maintained. So meaning to say that it is not the sole reason for maintaining the corneal transparency. Similarly, if the aqueous is replaced by the nitrogen, the cornea remains transparent. It turns opaque if both these sources of nutrition are cut off. Now this is again important. Individually both of them may not be important. If I am cutting either of them, then I am not getting the opacity in the cornea. But if I am cutting both of them, then I am getting the opacity of cornea. Metabolic activity exhibits a high rate of aerobic glycolysis as described below. Now this is again important. Now you will be reading in the lens that in the lens the main metabolism is your anaerobic metabolism. So there you will have the anaerobic glycolysis. 80% of the energy is coming through the anaerobic glycolysis, but when it comes to the cornea, it is actually the aerobic glycolysis that is the main one. So you should realize that there is a difference in the metabolic activity types, what are going in the cornea and in the lens. Now coming to the lens, lens is deriving its nourishment entirely from the aqueous humor. I think this statement is again very important, in which it is remaining immersed, the fluid traffic being regulated by the semi-permeability of the capsule and the subcapsular epithelium. Now when I am saying that the lens is actually dependent upon the aqueous humor for its nutrition, the second question is that how that nutrition from the aqueous humor is going up to the lens. So it is due to the semi-permeability of the capsule. Through the capsule it is going, and also the subcapsular that capsule as well as the epithelium that is present beneath that capsule. So if this membrane is disrupted, the whole tissue like the cornea tends to absorb the fluid and turns opaque. So if anything happens to this membrane, then whole of the lens will absorb it and it will become opaque due to the overhydration. Active transport takes place between the lens and aqueous owing to the activity of the subcapsular epithelium. Now this is also showing you again that the metabolic activity is not just taking place only due to the endothelium. Even the epithelium also plays some part in the metabolism, but it is the main thing when we talk about the endothelium. The capsule itself is permeable to water and the electrolytes as well as the colloids of small molecular size, and the posterior part is more permeable than the anterior part. So again this is important, the posterior part is more permeable, and this permeability of the capsule is also decreasing along with the age. There is a small amount of oxygen in the aqueous derived from the blood, but the main metabolic process is anaerobic. So I told you that this will be important because in cornea it was aerobic, but here it is mainly anaerobic, and in the lens there are also a number of enzymes. We also have the number of enzymes. These enzymes are breaking the pyruvate to lactic acid and water. Now if you remember, I always tend to ask you that if a lens is avascular, how do it manages with the nutrition? So we say that it is the aqueous humor which is giving the nutrition to the lens, and that aqueous humor is giving the nutrition via the lactic acid, right? So lactic acid is formed in the considerable quantity in the aqueous humor when the lens is present. Why? What is happening? That a continuous metabolic activity is going on in the lens and it is forming the lactic acid. That lactic acid is actually diffusing in the aqueous humor because we have semi-permeable capsules, and from this aqueous humor now indirectly the lens is getting the nutrition. So that means it will not take place in the aphakic eye. Okay. Now agents which appear to participate, we know about the antioxidative mechanism. So this is again important. We have glutathione, we have ascorbic acid, that is vitamin C, while reacting together. Okay. So this is your oxidative mechanism, that the former both as reduced and oxidized glutathione are present, and this is secreted by the ciliary body. The glutathione is coming from where? This is coming from the ciliary body. Neither is present in the cataract. The metabolic activity of the lens is largely confined to the cortex, and the older nucleus is relatively inert. So basically the things they are telling are the same, but the places at which they are telling is actually sprinkled here and there. So we have actually confined the things, like I have told you, the metabolic part of the lens and under the topic of lens only, metabolic part of the cornea under the topic of cornea only, so that it becomes easier for you to summarize there. But otherwise these things you already know, that the oldest part of the lens is the nucleus. Nucleus is inert. Then we have got the cortex. Cortex contains the superficial fibers, and they are the metabolically active part of the lens. Then what is antioxidative mechanism, what kind of metabolism takes place in the lens, everything like that. Okay, now the metabolism of the lens is fairly complex but can be simplified. The energy requirements are met by various pathways. So you have glycolysis, that is Embedden, Meyerhoff, Parnas, EMP pathway. We have got the pentose phosphate pathway. Also we have got the TCA cycle. Energy is stored in the form of ATP. Okay, most of the glucose which enters the lens, now 90 to 95% of the glucose is converted into glucose 6-phosphate by the enzyme hexokinase, and a small quantity is converted by the aldol reductase into the sorbitol. So this again you know that this aldol reductase converting into sorbitol, this takes place only in the metabolic diseases or the conditions. Normally this sorbitol pathway does not take place, and the name of the enzyme is again important, aldol reductase enzyme, which is responsible for the sorbitol pathway. Alright, the latter pathway becomes more important. As I told you, it becomes latter pathway means they are talking about the sorbitol pathway. So this sorbitol pathway becomes important when we have excess glucose in the lens, as in diabetes. About 80% of the glucose is then metabolized by the EMP pathway. I told you that about 80% of the metabolism taking place in the lens is your anaerobic glycolysis, which is the anaerobic pathway of glycolysis. 10% is your pentose phosphate pathway. In addition to generating the reduced NADPH, important reducing substance required for the biosynthesis of many cellular components such as the reduced glutathione, it also generates the building blocks. Building blocks means they are talking about the nucleic acids, the proteins, and the component of the cell membranes. Now, as the oxygen content of the lens is very, very low, 3% of the glucose is metabolized aerobically by the TCA cycle. Again, important thing. 80% is your anaerobic glycolysis. Okay. That is a major chunk, and only 3% is your aerobic, that is TCA cycle. Look at the ratio there. However, as the latter is more efficient in the generation of ATP, now this is 80% and this is just 3%, but this 3% is producing about 25% ATP because this is more efficient. So this 3% is generating 25% of ATP present in the lens, with 70% being produced by anaerobic, and the rest of the methods, that is this, then you have got the pentose phosphate pathway, they are producing 75%, right. The TCA cycle is taking place in the lens epithelium. So the aerobic metabolism that is taking place in the form of TCA cycle, that is taking place in which part of the lens? That is your epithelium. All right. Now the same thing they have shown here also with the help of a picture. So it depends upon you. Like some people are good at remembering the flow chart, so you can learn this flow chart like that. Or if some people are learning like learning in the form of a story, so that I have already told you, so you can learn that way also. Okay, so same sequence of events they have shown you in this table also. You can learn either way. So coming to the summary, the important physiological processes necessary for the functioning. We saw the blood-ocular barrier, the formation of the intraocular fluid, how the intraocular pressure is maintained, the transparency. Then we talked about how the disruption of the tear film was taking place, inflammation and all was leading to increased vascular permeability, leading to the release of more of the protein content. Aqueous formation was occurring by the two mechanisms. We had ultrafiltration, we have diffusion, we had secretion. Secretion was the main one. Okay, then I told you that some of the capillaries have they lack the tight junctions. Okay, and due to that we have got the sodium potassium ATPase enzyme working, and that can pump the ions. So because of the absence of that gap junctions, these ions can go out and in. So they will pump out the sodium and water follows. And then they talk about the carbonic anhydrase enzyme. Carbonic anhydrase enzyme is the enzyme which is responsible for the formation of aqueous humor. So in short, they have talked about the aqueous humor and the intraocular fluid as well as intraocular pressure, how it is formed, the drainage, the channels, how it is maintaining the transparency, the metabolism of the cornea and the lens. Then they talked about that how corneal transparency is dependent upon the fibril distribution, that is your Morris theory. Then an important line here, what they are saying is that the physiological functions of the lens are, that is your refraction, accommodation, absorption. So it is also absorbing the ultraviolet light, that is 360 nanometer or less. So that is again important, that lens is also playing as a filter for the absorption of your damaging ultraviolet radiations. Factors responsible for the transparency are again your lamellar arrangement, we have got thin epithelium, avascularity. Then all these things are asked as MCQ. See, a high concentration of glutathione protects the lens. Then you have got sodium potassium pump, that is also responsible for maintaining the dehydration. Then you have got the crystallines. So important thing that they are saying here is that the alpha crystalline prevent the aggregation of the proteins for the better transparency. Now till now we know that the crystallines are important, and crystallines, may beta crystallines were the most common one, 55%, alpha crystallines were the largest, but now they have specifically said that alpha crystallines are preventing the aggregation of the proteins. So alpha crystallines are basically responsible for maintaining the transparency. Then I told you that it has mainly the anaerobic metabolism, more than 80%, about 85% is your glycolysis. So with this we have finished the chapter number 2 also. I hope you have understood the 2 chapters. We have finished chapter number 1 and chapter number 2, and I am working on your suggestions. I have got many suggestions about the new quiz patterns you people have given to me, and your valuable suggestions, and you people want to synchronize your quiz with the Parson series. So I am working on that front also. I'll come up with some new ideas in a day or two. So till then keep on revising, okay. Finish up your chapter number 1 and chapter number 2, so that when we conduct the quiz on this, so you are already ready, and see you soon in the chapter number 3 in your next series. Thank you and happy ophthalmology.